to the cloud. So Tara is amazing. She is now working at the Banyan Treatment Center. Is that how you say it? In their business development office. And she has a long history of working in the field, as well as having her own lived experience in this world, in this realm. We had a Trauma Training Tuesday in the past where people shared their addiction stories, but they were both really participants in services. And Tara has sort of the advantage of being on both sides of the table, kind of really understanding how we think about treatment, how treatment's received. And one thing that's especially interesting to her is the larger environment, the larger culture, and how we can really be supportive of people in recovery. Many of you that do, work with people and care deeply recognize that the way we treat people that have struggled with addiction is so problematic and often really makes it so much worse. We really add insult to injury with some of the ways we behave around our thinking about addiction, our thinking about people in addiction. And so Tara is really going to bring that here to talk to us about sort of empathy, kindness, what it's like. And I'm just super grateful that she's here. Great to see everybody. Kelsa, I'm so glad you're here. I already said hi to Heather, Lou, Susan. We're super glad you're here. Sandy Ellis on vacation, tuning in to Trauma Training Tuesday, even. Amazing. So Tara, I'm gonna let you get started. I think I can spotlight you. And everyone else, you can feel free to mute, turn your camera off. She's got a slide deck, and I'm just gonna zip it now and turn it over to you. Thank you, Tara.
Thank you, Amy. Thank you. You're funny, you're spotlighting me, so I can't see everybody now, but I wanted to say a couple of hellos. I see Juan, I see Susan, I see Sandy, Jenna, good to see you. It's been a while. Acting Chief Jay Tamulin from Westminster, thanks for being here. Kelsa, good to see you. So I feel like, some of the information may be a review for some people. Doing a training like this, I find challenging in a way, not necessarily knowing my audience, right? And the information you have versus the information that you don't have. So what I always do is I typically kind of start from ground zero and I work my way up, because I feel like I don't want to assume that everybody has the same information that I have. So I can promise that you'll all learn something new today for sure. But I will also promise that some of it you may have already heard at one point or another. So I'm going to go ahead and share my screen. So bear with me just a second. Okay.
Beautiful. That looks great, Tara. Tara, I think people need to hear this stuff many times. All I do is trauma stuff and I still learn all the time and I never lose interest. So I wouldn't worry at all about what we already know.
That's good. That's good to hear, especially coming from you, Amy, because I was like, I'm just probably doing all this stuff and Amy's going to be like, blah, blah, blah. I've heard this all before, but I appreciate you saying that. So the presentation I kind of entitled today, Addiction 101, the intersection of substance use disorder, mental health, and trauma. We're going to go over barriers to accessing treatment and sustaining long-term sobriety. So we're going to really touch upon a wide variety of content today. And I don't want to talk at people. I really hope this to be an interactive experience. So I encourage people to raise your hand, come off mute, ask questions. I'd rather not wait until the end of the presentation to take the questions. If I'm discussing something and you have a question pertaining to that, please interrupt me, ask the question. If you have a scenario you want me to go over, feel free to do that. And I have to also, I'm on call, so I have to also check my text messages. Amy, I just got a message. Do you have a link for the training? It will not work by typing in that link on the flyer. Can you possibly text me, Amy? And then I can just copy and paste and text that individual. That would be helpful. So, all Absolutely. Right. So thank you. So I'm going to be talking, I'm going to be training, I'm going to be responding to my text messages. I'm going to do it all. So
Yeah.
bear with me while I do that. So let me go to let me advance my slides. All right. So for those of you that don't know me, my name is Tara Vera. I am currently a treatment advocate at Banyan Treatment Centers. Banyan Treatment Centers, for those of you that don't know, has 2 locations in Massachusetts. The first location is primary substance use disorders. We do detox and CSS level of care, which we'll talk about a little bit later so you guys understand what that means. And that treatment center is in Baldwinville, Massachusetts, and we also do mental health in that center. So at our Baldwinville location, we do substance use and, obviously people that have co-occurring disorders. We have a mental health track. So we have a male and a female mental health unit. So we can take folks that just have primary mental health issues. They don't have to have any substance use disorders. And then we have a third unit, which we just opened, which is for first responders and frontline staff. So first responders being anybody that's worn a badge, police, fire, EMS, dispatch, veterans, and our frontline staff being medical, behavioral health professionals. So it could be nurses, it could be PAs, doctors, social workers, therapists, et cetera. So we have a whole separate unit just for those folks. So they're not interacting with any of the other clientele in the building. So I work very closely with a lot of first responders that do peer support and help different officers and law enforcement professionals, veterans access treatment. We all know that addiction is a highly stigmatized disease, and it's even more so for those that wear uniforms or wear badges. And so it's an honor and a privilege for me to be able to work with that population as well. So I'm proud to say that we do that. And then in our Wilmington location, we have a PHP and an IOP. So that's, we'll go over what that is as I go through the presentation. And that is typically, I would say, anywhere from like 30 to 90 days. And we have a sober living out there as well. So if they want to start in the Baldwinville location, do detox and CSS, they can transition to our Wilmington location, live there, and do a PHP IOP as well. So that's really cool to be able to offer a full continuum. It's awesome that I'm able to offer mental health, because I wasn't able to do that before. So that's exciting for me to be able to do. And then obviously to work with our first responders. So that's a little bit about what I do at Banyan. I'm also an adjunct professor of addiction studies at Anna Maria College, which has always been a dream of mine. I absolutely love to teach. I believe that education is what's really going to break stigma. And so I have the ability to create my own 8-week course at Anna Maria College. And I've taught that now for 3 years consecutively. I would love to teach it elsewhere because I feel like what I get for students there is I'll get social work students, I'll get law enforcement students, I'll get business majors, people in all different sectors. And I get to teach them a little bit about what you guys are going to learn today, because we're all going to be impacted and we're all going to be affected and we're all going to meet someone one way, shape, or form, whether it's personal or professional, that struggles with substance use disorder. So when you have a real understanding of the whys and the who's and the what's about it, I think you're going to be that much more well equipped to handle dealing with someone that's struggling with substance use disorder. So I'd love to be able to teach that class. It's an honor and a privilege. I've also hosted a recovery radio show. I was recorded some podcasts, educational podcasts regarding addiction in the past, and hope to do that again in the future. I am the director of Facing Addiction in North County. I do that work in collaboration with the Joint Coalition on Health, and Susan Buchholz is here today, Amy Ebsen, also Sandy Ellis. We have a wonderful group of people who are working tirelessly in North Central Mass, and it's an honor and privilege to be part of that group as well. And then community faculty for UMass medical students. We've run clerkships for several years now for UMass medical students. We've brought them into the community, Fitchburg, Leominster. We've introduced them to places like Restoration Recovery Center, the Spanish American Center. We've been able to give these students a firsthand view, or bird's eye view, if you will, of what's happening in the community. I think sometimes our providers are kind of like up here, right? And then us folks that are like, boots on the ground, the recovery coaches and the treatment advocates, like there's always this disconnect. So it's really a privilege to be able to get these medical students before they're up and running, and get them engrossed into the community and educated about what it really looks like for someone that's struggling with substance use disorder, or someone that's trying to help someone recover from a substance use disorder. So that has always been amazing. And then last but not least, I'm a person that's personally affected by the disease of addiction. So what that means for me is it's generational, right? So I grew up in a home where both my parents struggled with addiction. Both my father and my mother had a problem with alcohol and drugs. There was lots of illegal activities happening in my home as a child, lots of trauma, lots of stress, lots of dysfunction, chaos. And so naturally, when my father died from the disease when I was 11 years old, my mom got sober, which was a blessing. So she's got 34 years, I think, of sobriety now. But that, unfortunately for me, was the time that I chose to pick up substances to self-medicate from losing my father, and essentially losing my mom, because her recovery became her full-time job. She went to AA meetings and NA meetings 3 times a day for the first several years of her recovery. So she really was not available for me. So, the first half of my life was my parents' active addiction. And the second half of my childhood, I had lost my father, and my mom was unavailable because she was working on her own recovery. So I chose to pick up substances. At that point, I was about 12 years old, and I used substances until, I was 15 when I went into my first rehab. So things spiraled out of control relatively quickly for me. I felt immediately like this is exactly what I've been looking for. Like, this is the relief I've been searching for. These are the people, these are my people, right? They love me unconditionally. Like, they get me high when I want to get high. They give me alcohol when I need alcohol. And, that was just, I thought I was living the life. So 15 was my first rehab. I didn't stay sober more than about 6 months at that point. I was still in high school. It's very challenging, obviously, to stay sober while you're in high school. And so I went for a few more years. I was 19 years old when I reached out to my mom to ask for help, because obviously she was in recovery at that time. I think she had like 8 years. And I basically, from the outside, I had everything all together. So nobody knew what was going on inside my home. So I was 19 years old. I was working full time. I was going to school at Mount Wachusett full time. I had a car, so on the outside, everybody thought I had it all together and, things were fine. But on the inside, things were not fine, right? I didn't want to go anywhere, see anyone, talk to anybody. I didn't want to share anything I had. I didn't want anybody to know what I had going on in my house. I was a professional at putting the mask on and making pretend that everything was fine. So when I asked my mom for help, she was kind of like, what do you mean you need help with what? Why? So I kind of had to come clean and tell her what had been going on and what I've been doing, and that I wanted to stop. And so she helped me. She told me to meet her at her meeting that night, which I was very familiar with the meetings and where they are and where to go and what to do. And that was it for me, knock on wood. So I have continuously been sober since January 21st, 1997. So 26 years of continued sobriety. And it has not been easy. And we'll get into, as I get into the presentation, different things over the years that I have discovered and worked through and recovered from, and things I'm still recovering from. But what I do want to say is, additionally, I had 2 brothers that struggled with their own addiction for 20 years after I got sober. So I was sober. I had a little brother and I had an older brother that were struggling in their own addiction. And it was terrifying. And as we go through and we talk about trauma, I'll share some traumatic experiences I had watching them go through their addiction, car accidents and jail, and just, it was craziness. So I'm sober and my life is great, but I'm watching my brothers completely, lose control of their lives over a 20-year period of time. So luckily, I'm happy to say now my older brother is 8 years sober. And he got sober when he was 40. He went to a program called Teen Challenge, which is a faith-based program. His was in Manchester, New Hampshire. There's one here in Brockton, Mass. They're all over the world. Phenomenal programs, faith-based programs. He graduated the program after, I think, 15 months or so, stayed on his staff, went back to school. He's now a reverend, and he's the assistant program manager of that Teen Challenge he once graduated from in Manchester, New Hampshire, which was beautiful. My younger brother, I ended up having to Section 35 him, which was a very challenging, emotional, horrible thing for all of us. He was very angry with me and didn't talk to me for about 2 years after that, but he is now 6 years sober today. And I do firmly believe if I had not done that, he probably wouldn't be here, or he would be in jail for murder, because he was constantly driving drunk. Like, he just had there was no moral compass. He was, he would be drunk for days on end, and he would be driving, and he had numerous DUIs where he, lost his bumper, didn't know where it was, woke up in the morning, didn't know where he had been or what he had done. And I was like, he's going to kill himself or someone else. I can't stand by and watch this. So I was forced, I feel, to Section 35 him, but grateful today because he is sober as well. So both myself and my mom and both my brothers now are all living in recovery, which looks very different for each and every one of us. We all run our recoveries very different. My brother is very faith-based. My younger brother kind of has made his own way. I'm pretty faith-based myself, but very different from my brother. And my mom is very different as well. So we're living proof that you can recover and that there are multiple pathways to doing so. And nobody should judge one another on like what their recovery path looks like or what their recovery journey looks like. So that is a little bit about me. I will continue with more personal stories as examples as we go through the slides. But I just wanted to kind of give you an idea of my experience, right? So I also have a master's degree in business. So, and I've been working in this field for about little over 7 years now. So I have experience with growing up in a home where people, were alcoholics and addicts, right? Which I hate to use those terms, but living up in a home where there was active addiction. So I was a child of, two folks that struggled with their own addiction. I struggled with my own addiction. I was a sibling to two brothers who I watched them self-destruct for 20 years. And I've worked in the field for 7 years. And I get it, right? Like, I get it. So this stuff is ingrained in me. I could talk about it every day, all day. Stigma is real, and people are dying way too rapidly. And so these types of trainings, I think, are really crucial. So I would say, give yourself a hand for taking time out of your day for being here. And I hope that you do learn something new. Okay, I can't see the chat. So Amy or anybody else that has access to the chat that is on the Zoom, if you want to interrupt me, if there's a question or something that I need to address, definitely let me know, because I'm not seeing that as I'm looking at just my slides right now.
Yeah, we let people know that they can jump in or use the hand raise feature because you can't see them.
I can't see you, which makes it so much easier to present sometimes. So yes, come off mute, interrupt yourself, say, excuse me, I had a quick question. But Amy, if you do see something in the chat, please feel free to interrupt me as well and let me know what the question is. So the first thing I like to talk about when I do any type of training like this is words matter. Our words are very powerful, and they can help someone heal or they can hurt someone really bad. So as I talk about substance use disorder, mental health, trauma, et cetera, you won't hear me use like terms like addict, junkie. I don't even like to self-identify when I go to a 12-step meeting as an alcoholic or an addict. I say, I'm Tara and I'm a person in long-term recovery, because for me, I believe those types of terms bring a negative connotation with them, right? So I use medical terms because this is a disease. And when we talk about cancer, we talk about it in a medical way, right? We talk about diabetes, we talk about it in a medical way. So we need to change people's perceptions. And the way that we do that is changing our language and the way that we speak about those who struggle with substance use disorder. So when someone says substance abuse, it's like nails down a chalkboard for me. I'm like, please don't say that word. It's just such a not nice word, right? So it's substance misuse or substance use disorder. Abuse really has a negative connotation to it. I would love, love, love for us to get away from using that word. If anybody gets nothing out of today, like, please let's stop using the word abuse. The next word is clean or dirty. Like, for those of you that work in the medical field or treatment centers, even the judicial system, right? If you have a person who's on probation and they go in for a urinalysis and it tests positive, they say, oh, so-and-so so-and-so was dirty today, we're going to violate their probation. Like, that is not accurate. And it's not professional. That you had a urinalysis done and the person tested positive for X, Y, and Z substances. That's how we're talking about these things today. Because again, it has a negative connotation. And it's just not necessary. Those are all hurtful terms, and it keeps us in like this negative space when we talk about substance use disorder. So we tested positive for substances, or it was negative for substances. And then, like I mentioned, obviously, person in long-term recovery, I don't like to identify personally as an alcoholic or an addict. If I'm talking to somebody one-on-one and I'm doing, peer support and it's necessary in that environment, I will. But in an open environment like this, I'm doing an educational session or I'm teaching in any way, shape, or form, it's a person in long-term recovery. Celestina, did you have a question?
Yes, I did. I wanted to ask if you could explain a little bit more about why substance abuse, is a negative connotation or tone. The way I'm I'm soaking it in is there is, for example, painkillers, and we know we're not supposed to overuse it. So when you use it without knowledge, is it not abuse? And I'm only asking because I do want to soak their understanding in. So when I have to explain to someone else, I'm more confident explaining why you shouldn't use substance abuse versus, disorder, because the word abuse is I'm fully aware of what I'm doing, or maybe not, but I'm misusing something. Yes, I'm just going to end it there.
Yeah. No, thank you. I appreciate that. So, and I encourage others just to, raise your hand and ask questions, because again, like I said, I want it to be interactive, and 9 times out of 10, if you have a question, someone else probably has the same question, or you're going to give them confidence to ask questions. So thank you for the question. We don't like to use the term abuse. It is, right? Like, I abused alcohol and I abused drugs, but what's the difference between me abusing them and misusing them, right? So it's the same thing. But when you hear the word abuse, you automatically think like, you think child abuse, right? You think like a really negative, very bad thing. And if we're trying to change our mindset when we're thinking about someone that struggles with substance use and it's a disease and it's not a choice, then we want to say they're misusing their prescription, or they have a substance use disorder. Some people haven't reached the point where they have a substance use disorder. They may be in the misuse phase, right? So, but if they're in the misuse phase, are they really abusing, or are they misusing are they misusing the substance, whether it's a pill or whether it's, wine at the end of the day. So it's just the fact that it has a negative connotation to it. So we want to use misuse and substance use disorder. And if you're talking to a client, think about it this way, and we'll get into it a little bit more and as we go through the presentation, but usually people that have a substance use disorder that have been in our system for any period of time are expecting to be treated unkindly, right?
Mhm.
That's just the general consensus, is our patients that have substance use disorder are not generally treated nicely when they go to the doctors or they go to an emergency room or anything like that. So you, as a clinician or peer support or whatever you're doing, if you're talking to them and you're using these terms, if you have a substance use disorder or are you misusing substances, you're almost like showing them respect, which is something they probably haven't felt from any type of a provider. And that kind of sets you apart. And now you're building trust and rapport with that individual as well.
That's very great. So it is safe to say substance misuse, but not great or just avoid using abuse, and it's also safe to use substance use disorder. Did I
Yes.
understand? Okay, thank you. Sorry for
Yep.
interrupting.
No, I appreciate that. Thank you so much. I think it's a great question. So in general, we want to get used to using more medically based terms, more professional terms when we are talking about substance use disorder, because a lot of people still feel like this is a choice, right? And that it's a moral failing. And like I said, our patients, our clients are being mistreated and looked down upon and shunned like daily. So if it's just that one individual, it's just Celestina is the first person that, this patient has encountered that has used the term substance use disorder or misuse, and they're like, wow, no one's ever said that before. And you're making them feel less guilt and less shame. You're building that rapport and you're building that trust in them, and you're building their confidence back up in themselves. If they're struggling with substance use disorder, I promise you, they already feel absolutely terrible about themselves. So why are we going to go ahead and reinforce how they feel about themselves versus we're going to build them up and we're going to encourage them? And this is happening right now, and that's okay. It's a substance use disorder. We recover. We do recover. I know people that recover. I've recovered myself. This is just where you're at right now. It doesn't mean that's where you need to be tomorrow or 2 weeks from now or 2 months from now. So it's a very powerful thing. Our words are so important. And I'm going to continue to harp on that as we move forward. So the next big thing I like to talk about when talking about like stigma or how people perceive things in a negative way, the term harm reduction, right? So we hear harm reduction, often that gives people a negative emotion for some reason. They're like, harm reduction. Yeah, that means like what we're giving people needles, clean needles. They go use drugs. Like this doesn't make sense. Like there's a lot of that still happening in our community. But if you think about harm reduction in your day-to-day life, if we play sports, we stretch first, right? If we're trying to lose weight, we reduce our carbs, we reduce our sugar, we add exercise, we're drinking lots of water. If we want to avoid pregnancy, we use contraceptives. If we're trying to quit smoking, then maybe we'll say, okay, I smoked 10 cigarettes today. I'll try 9 tomorrow. We'll try 8 the next day, right? Those are all harm reduction methods. And that's realistically, if we think about our day-to-day lives, we're doing that all the time, right? So when we think about harm reduction in terms of substance use disorder, why does everybody get so up in arms about it? Because realistically, like harm reduction is what we do on a day-to-day basis, whatever our goals are, losing weight, building muscle, quitting smoking, quitting coffee. Like we all have something that we need to work on. So we're gonna utilize harm reduction methods to help us get to our goal. Same thing with those that are struggling with substance use disorder. Their harm reduction may be less beer today. Their harm reduction may be, I'm not going to use needles. I'm going to try this instead, or I'm going to try to do the right thing. I'm going to use clean needles. I'll try not to expose myself to different, diseases, etc. Whatever that may be. Why does that have to come with so much stigma and judgment? They're working on moving in a better direction. So we need to really get rid of the stigma that comes along with that word harm reduction. Abstinence may be the ultimate goal, maybe not, but it's all about moving and taking steps in the right direction. I want to lose 10 pounds. Who doesn't want to lose 10 pounds, right? So are we going to, drink water and exercise and eat right for 1 week and expect to, lose that 10 pounds? We all know once we get older, those things are a lot harder to accomplish, right? And so we need to celebrate the baby steps and the milestones as we're moving through that process to get to the point of losing the weight. And it's the same thing when it's someone that's struggling with substance use disorder. So that's a little bit about harm reduction. So addiction. What is addiction? Why is it classified as a disease? Now, as someone that struggled with it myself, I didn't know this stuff. This was all new information for me. I was about 20 years sober when I started working in this field, and I didn't even really know any of this. I was like, oh, okay, so it's a chronic relapsing brain disease. Well, that makes sense as to why so many of my friends and family members have struggled in their disease, their addiction, and have had these chronic relapses. relapsing. Like I know personally friends, family members who have tried to get sober and have chronically relapsed over the years. You know, they may do 9 months and they may have a relapse, which I don't like to use the word relapse. I like to use the word reoccurrence, but so why is it? It's defined as a chronic relapsing brain disease. Why is it characterized that way? Because despite the harmful consequences, we continue to do the same behaviors, right? We continue to drink, we continue to do drugs, even though we know there's harmful consequences. We may lose our house, we may lose our job, we may lose our spouse, you know, we may not be able to be involved in our kids' lives anymore, but it's a chronic relapsing brain disease because even in spite all of those different things, we're still going to continue to do what we're doing until that cycle of addiction is broken. The reason why it's considered a brain disease specifically is because it changes our brain, the structure of our brain and how it works. And how does it do that? So the part of our brain that is primarily affected by the disease of addiction, not the only part, but the primary part, is our prefrontal cortex. This is our most elemental part of the brain. It's the part of the brain that tells us to wake up every day, to find food, to find water, to find a mate. Like, this is our survival part of the brain. And it gives us positive reinforcement for doing that. So we find food, we find water, we find a mate. It increases our dopamine in our brain. So that teaches us that, oh, this is good. This behavior is good. It's helping me survive. It's helping me not be dehydrated. It's helping me be healthy. It's helping us procreate and populate the world. So our body releases dopamine when we do that. So it teaches us to continue to do those behaviors over and over again, right? Dopamine gives us a sense of euphoria, but it's also associated with compulsion and perseveration, which is why usually once the brain is addicted, that's the only thing it thinks about. And it doesn't think about the wife and the kids and the job and all of the other stuff. So this is probably, I always say this, but this is one of my favorite slides. And this is, I think, so relatable for all of us, right? We all have something, whether you eat things you're not supposed to eat, whether you drink coffee every single morning, whether you are trying to lose weight, doesn't matter what it is. Like, we can all relate to this in one way, shape, or form. So what happens in our brain when we have a good meal? Well, our dopamine increases to about 150%. When we have a sexual experience, it goes to 200. Cocaine brings it to 350. Opioids, prescription opioids, 500. Heroin, 900. Methamphetamines, I can't see because my knees on the line, 1,200. I should have that memorized by now. So what happens is, okay, we eat a good meal, 150. We digest the food. Our dopamine goes back to 100, no big deal. We have a sexual experience. It's great. We want to repeat that. At 200%, our dopamine very easily goes right back to 100, which is, where we start. Baseline dopamine level is about 100. Sorry if I didn't say that already. So normal baseline dopamine level is 100 every day. So you do have a good meal, 150, go back to 100, no problem. Sexual experience, 200, go back down to 150, no problem. Cocaine, 350. It's really, really high. You might want to repeat that behavior, but you still don't really have too much of a hard time going back down to your baseline dopamine of 100. When you start getting into the opioids and your dopamine levels at 500, heroin 900, what happens in your brain, these alarms go off and they're like, whoa, we have an overproduction of dopamine. We have to stop producing dopamine. You got to stop immediately. We have, we're at 500. We got to stop it. So your brain tells your body to stop producing the dopamine because you're way up here, 500, 900. Well, what happens? Do you go back down to 100? Maybe the first couple of times, maybe. But what happens over that continued use, because your body stops producing its own natural dopamine, now instead of going back to 100, your body's going to 80, 75. Some people go as low as 35, 40%. There's no more getting to that 100 level because our body is no longer producing its own dopamine because our brain had all these alarms going off and told our body to stop producing it. We don't need anymore. We don't want anymore. Shut it down. So if you think about, I tell people all the time, you think about how you feel first thing in the morning. Your dopamine level is 100. What's the first thing most people do when they wake up in the morning? I'm not a coffee drinker, so it's not coffee for me, but I would say more than 50% of you probably are like, coffee, right? And not only coffee, but don't talk to me until I've had at least 1 cup of coffee, right? Or don't talk to me until sometimes I've had 2 cups of coffee in the morning. And I know many people that are like that. You know, coffee is always the first thing that they go to in the morning. Why? Well, because it releases dopamine in it. It gives you caffeine and it helps you feel better. That's your vice, right? I don't drink coffee, and I'm not saying like, oh, I don't drink coffee, I'm better than, I don't like the flavor, I don't like the taste of it. That's why I don't drink it. And it never did anything really for me. So anyway, so you're waking up first thing in the morning and your dopamine level is 100. How do you feel before you have that first cup of coffee? Usually you feel pretty crappy. You're pretty crabby. Very few people I know wake up and feel like, yay, it's Tuesday, the sun is shining, it's going to be an amazing day today. Like, how many people actually wake up before having coffee or anything in that frame of mind? Very, very few people. So if you go back to thinking about someone whose brain has been hijacked now because they're in active addiction, their dopamine level is no longer 100. Their dopamine level is at 45%, 30%. What do you think that they're going to think about the first thing when they wake up in the morning, right? You constantly think about, I need to wake up and have my coffee, or I need to wake up and have a shake, or whatever it is that you do, because you need that to get your day going. And your baseline dopamine level is at 100. Imagine waking up with your baseline dopamine level at 35%. I can understand. I'm not condoning. I can understand how somebody would feel that the only thing that matters to them, they've got tunnel vision. The only thing that matters to them is that first drink or that first high, because it's going to bring their dopamine level back up to where they're used to it being, and they're not feeling super crappy anymore. So I like to say that's one of my favorite slides because I feel like it's one of the most impactful. A lot of people have no problem judging someone that struggles with an alcohol addiction or a drug addiction, yet we don't really think about cigarettes, or we don't really think about caffeine or all of those things, right? None of us have walked away from any of this unscathed, right? We all have things that we probably could get rid of in our life, or at least reduce doing in our life. So I like to share that. So the next thing I like to talk about when we're talking about addiction, because now we understand that this is a brain disease, right? It's a reoccurring brain disease. Well, for me, if you're looking at diabetes and addiction, the two are directly correlated. There's a disruption in the transmission or the production of glucose when we're talking about diabetes. When we're talking about addiction, it's dopamine, right? Same thing. Our brain's not processing it properly. Either we're not making enough, we're making too much, our body shuts down, we're no longer producing it, right? So common causes of both is genetics, lifestyle, environment, right? For both diabetes and addiction. So my father was diabetic. He was diagnosed when he was like 13. And then his mom actually my grandmother who raised me, ended up getting diagnosed when she was like in her 70s or 80s. I want to say maybe even 80s. So there is a genetic, I knew growing up, my father had diabetes and there's a genetic predisposition and we need to be careful. My grandmother was always like poking my finger and testing me when I was a kid, making sure I drank enough water and don't have too much sugar and all of that stuff. So, but there was no shame attached to that. There was no shame because my father had diabetes, but we don't have those conversations with our kids, I do. And we'll talk about that. I'm very, very open with my daughter. She's going to be 12. She probably could teach this for me because she's heard me do it so much, which is a blessing. But she knows that she's genetically predisposed to the disease of addiction because I struggled with addiction. My mom struggled with addiction. My father struggled with addiction. She's got addiction on her father's side of the family as well. So she's very well aware of that. Well, I was very well aware I had a genetic predisposition to diabetes growing up, but no one talked to me about the addiction piece. Whether that would have made a difference, I don't know, but those are conversations that we don't have that we probably should be having. Obviously age appropriate, right? So I've been doing this work, I say 7 years. So I've been having these types of conversations with my 12-year-old since, for the last 7 years. But when she's, 5 years old, 6 years old, 7-year-olds, we're not talking about alcohol and drugs. We're talking about making good choices. We're talking about our feelings and how to handle it when we're feeling sad or we're feeling, angry. We talk about, well, when we feel this way, what's a good way to handle that? Should we go for a walk? Should we have a good cry? Do we want to use our journal and write our feelings out? Right. So I don't have to talk about addiction and drugs and alcohol with my 5, 6, or 7-year-old, but I certainly want to incorporate how to deal with our feelings, how to deal with our thoughts, healthy ways to kind of express those things, right? Because when it comes time, do I want her self-medicating the way that I did? No, I want her to have the skills to, deal with those emotions and those things that life throws at us without having to, self-medicate. So back to the diabetes addiction thing, some people that have diabetes need to use insulin. Some people that struggle with addiction need to use MAT. Not everybody that struggles with diabetes needs to take insulin, right? Some people take pills. Some people just can regulate with diet and exercise. Same thing with addiction. Not everybody needs medications, right? Some people can manage without. Some people take medications for a period of time and then they're done. Some people take medications for their lifetime. Some people don't take medications at all. There is no rhyme or reason, and there is no right, and there is no wrong, and there's no place for us to judge, right? It's what is right for that individual. But I like to talk about this slide. I like to talk about diabetes versus addiction because the two can't be more similar. But if someone has diabetes and they've been eating poorly and not exercising, not taking care of themselves, and their sugar skyrockets, and they rush to the emergency room, how are they treated when they get there? Right? Are they like, oh, hey, John, geez, we saw you last week. We told you to lay off the Hershey bars. Like, what's going on? You need to drink more water. You need to eat less sugar. Like, go see your endocrinologist. Like, nobody talks to people that way, right? But when someone shows up in the emergency room time and time again, and they've had an overdose or an abscess or whatever the case may be, and it's due to their active addiction or their staff are assuming it's due to their active addiction, it's like, like you again. And, they're not met with compassion. They're not met with acceptance. They're not met with any type of positive reinforcement whatsoever. I mean, there may be some staff here and there. I mean, I want to say they're all like that because that would be unfair of me. But for the most part, if someone goes into the emergency room, their sugar's out of control because they have diabetes, they're treated very differently than someone who has an overdose or some kind of issue due to their active addiction. I can tell you that. I think all of us can probably agree to that. And if we get to a place where that is not the case, then I won't have to do these talks anymore. But, fingers crossed, hopefully doing these talks makes an impact in how people are treated because that's ultimately the goal. This is really powerful information for those of you that have kids, work with kids, any way, shape, or form. So I heard this really early on when I started doing this work a few years ago, and it was mind blowing. It was a game changer for me. And I feel like if we have all the money in the world, one of my biggest wishes would be to have this information on billboards everywhere. Now, listen carefully. This is a pediatric disease. Addiction can be preventable. Why do you say that? How can we prevent it? Statistics say if you use substances before you're 21 years old, you have a 40% chance of becoming addicted. 40% chance if you drink or do drugs before age 21. That percent drops to 7 if you wait until after you're 21, because your brain is not fully developed. As you can see here on the slide, the pictures of at age 12, age 16, age 20, there's less green and gray and blue matter. Your brain is kind of fully developed between 21 and 24. So I tell my daughter, right, I'm arming her with this information. I'm empowering her with this information. You have a genetic predisposition. Okay. So I'm not saying you're 100% going to struggle with substance use disorder yourself, but it's in your genes. So please be mindful. 2, if you use substances before you are 21 years old, your chances of becoming addicted are 40%. If you wait until you're 21, those chances diminish to 7%. So why not wait? Why chance it? So that's what I want on a billboard. That's my, if anybody has money for a billboard, that to me is such impactful information. Do our youth know that? No. Do our parents know that? No, they need to. Everybody needs this information. This is so critical. So critical. So I tell my daughter, I'm never going to tell you never to drink. I'm never going to say that. I'm going to tell you to wait until you're 21. I'm going to tell you then you need to make an informed decision, knowing the risks, knowing that I struggled myself, knowing where you came from. But if you wait until you're 21, your chances are going to be that much lower. So we'll see what happens, because like I said, she'll be 12 next month. So we're not there yet, but I'm laying a strong foundation and I'm giving her tools so that when the time comes, hopefully she makes a good informed decision for herself. Okay, so contributing factors of addiction, genetics, obviously, environment, right? So in your childhood and or your current living situation, what does that environment look like? And then there's other factors, and this is obviously not inclusive, but there's untreated mental health and trauma, which play a huge role in those that, begin to struggle with alcohol and drug addiction. So currently the statistic is between 40 and 60%. So 40 and 60% of us that struggle with addiction were genetically predisposed. My guess is that's probably higher than that, just from working in the field and talking to other people like myself. 9 times out of 10, it's my mom struggled, my dad struggled, my uncle struggled, my grandparents struggled. One way, shape, or form, there was someone in our family that struggled, right? So genetics plays a huge role. And so I really feel strongly we need to have those conversations with our kids, even if it's an uncomfortable conversation. 15 years down the road, had you had that conversation, now your kid may be struggling with substance use disorder, you're going to feel a little bit differently about maybe having had that uncomfortable conversation when they were 12, instead of sitting in an emergency room because they've experienced an overdose, right? And I don't mean to say that in a nasty way, but we either have an uncomfortable conversation now, or, we may be in an uncomfortable situation another 10 to 15 years from now, depending on the choices that our kids make, because we're not arming them with the facts. They need to be armed with the facts so they can make educated decisions. Some may not make good decisions, even when they're armed with the facts. We can't control that, but at least arm them with the facts. Environmental factors. So we are all familiar what a risk factor is, and we're I would think pretty familiar with what protective factors are. But risk factors, we've kind of talked about genetics, mental health, poor self-esteem is another one, lack of family involvement, and then early use, which we talked about. I can tell you from a very young age, I had terrible self-esteem, terrible. I had an older brother, older sister, and then there was myself, and I had a little brother. So I wasn't really middle, but I was kind of middle. Both my parents struggled with addiction, right? So both my parents were unavailable to me. There was no love in the house. There was no I love you. There was no reading books. There was no bedtime. There was no such thing as that. We ate what we wanted. We did what we wanted. We went where we wanted. There wasn't really any structure. There was no control. There was no nothing, right? So there's no security. There's no family involvement. There's no none of that. How does that make you feel about yourself, right? I remember being young and my friends being like, your mom is so cool. Like, she lets you do this and she lets you do that. And I remember very, very vividly feeling like, I don't think it's cool. I feel like she doesn't love me. I feel like she doesn't care. That's a crappy feeling, right? As a kid. So not only did I get it from my parents, But my older sister and my older brother were from my mom's first marriage. So then I came, so I was the first with my mom's second husband, my father, and then my little brother. Well, my older sister and my older brother were always against me because they were treated like stepkids by my father. He didn't treat them as well as he treated me. That isn't anything I had control over. I'm a kid. I cannot control how my father behaves or what my father does. But I was like the apple of his eye from what everybody tells me as being a kid. And he was very hard on my brother, very hard on my sister. He was physically abusive with my older brother. I grew up watching my older brother be beat almost every day. Realistically, was kind of like our life. There was a lot of violence in the house. So I was spared from that, right? My father did not treat me that way, thank God. But my older sister and my older brother resented me for that. And they treated me as such, right? So my father may not have mistreated me the way that he mistreated them, but they made sure I got my fair share. They didn't treat me very well. So from a very young age, I remember I can sit here and I can just, rattle off all the names that my older brother used to call me. I was insecure. So my father is Hispanic, he's Puerto Rican, and my mom's American. Has Irish and French. So my older brother, my older sister, their dad was Puerto Rican as well. They're darker olive skin. So I was like the white girl in the family. So they would always make fun of me for that. I kid you not, from probably, I don't know, 4th, 5th, 6th grade till high school, I wore nylons every summer, all summer underneath my shorts because my older brother made me feel so insecure about my skin color. I have freckles. And so, I got made fun of for that. I was fat. I had a pig nose. I had all of these things, right? So luckily I only have one daughter because the sibling stuff and kids, brothers and sisters talking poorly to each other, that is like nails on a chalkboard to me. Those words matter. Those words never went away. So I had 2 parents who I felt didn't care about me. My brother and my sister were so mean to me. My self-esteem was shot. I felt like a big piece of crap. And I felt unlovable and ugly and all of those things, right? So what am I going to do, right? I'm going to self-medicate because that's what I see both my parents doing. And it seems to be working for them. They don't care about anything. And I didn't have any of these protective factors in my life. What we talk about, like resiliency. What does resiliency look like? Well, now I know today as a 40-something-year-old woman, that I am resilient and I am confident and I don't listen to those lies anymore and that stuff that I, grew up hearing. But as a kid, I didn't have that. I didn't know what that was. I didn't have any positive influences in my life. Strong bonds, family, community. I didn't really have that. My mom ironically did make us go to Sunday school, which I thought was so odd for 2 people that were in the house drinking and drugging all the time, that they made us go to church on Sunday. But thank God for that, because that's where I found my peace. And that's where I found my strength. And that's where I found love, was really at church. That one day a week, I got to escape my crazy life at home and I got to go to church and I got to pray and listen to music and know that whoever this God is loves me, even though no one else in my house does. This God, whoever he is, he does. And I really thoroughly enjoyed going. And I went from the time that they sent me, which was probably like kindergarten, to time I started using, I would say 11, 12 years old. He was a big part of my life. Obviously, during my active addiction, he wasn't. And now today he is a huge, huge part of my life. I go to church every Sunday. I teach my daughter all about God because I still to this day carry some of that stuff, the poor self-esteem and all of those things, but I have confidence in him. He gives me confidence. He gives me strength. And I want my daughter to have that, even though I have those protective factors in her life, because we do have strong family bonds and she's involved in an awful lot. And, her self-esteem is 10 times better than mine ever was, but I still want her to know, God forbid anything happened to me, she can always rely on him because he's never, ever going to go anywhere. Right. So self-esteem, my daughter, like I said, I always use her for an example because I'm proud of who she is as a almost 12-year-old girl. I've never once heard out of her mouth, I'm ugly, I'm fat, like, I don't like my hair, my teeth, nothing ever. And that was like, that's all I said every day to myself as a kid growing up, like, oh, my hair, my clothes, I'm not this. I felt uncomfortable in my own skin my entire childhood. This little girl, because of the protective factors, right? Every single day of her life, I woke her up. Now it's not as much because she's getting older and she's kind of like over the like huggy kissy stuff. But for years on end, I woke her up like hugs and kisses. I love you. You're like the best thing that ever happened to me. Like, I'm so grateful God chose me to be your mom. You're smart. You can do anything you set your mind to. You're funny. You're kind, you're caring, you're compassionate. I mean, I was her cheerleader and still am. And to this day, I have to, say like that, I have to give myself a pat on the back. I have to give her a pat on the back because I was so hell bent on making sure she didn't struggle in that way, the way that I did. And I've so far, knock on wood, have succeeded. She's a very, very confident kid, which just makes me really happy for her because our kids these days, I'm a soccer coach. And I can tell you, our kids are not confident kids. Our kids need more confidence. Our kids need more resiliency. Those are the things, those are the protective factors that are really going to come into play when we're talking about like, okay, are they going to go into this early use? Are they going to make right choices? Well, if they're not comfortable in their own skin, they're not confident in who they are, they're probably going to make poor choices. So we need to build those protective factors. And even if you aren't a parent or your kid is not young, you maybe work with parents or you may volunteer in some capacity. Don't underestimate your power in that kid's life. So one of the most impactful people in my life was my high school guidance counselor. I still keep in touch with him today, and I still credit him for helping me become the person that I am today because he spoke into my life and he told me I could do anything I put my mind to and that I was more than where I came from and that those things don't have to hold me back. I had another woman who helped me get my GED who did the same thing for me. I had a family from the church who did the same thing for me. So no, I didn't have those things in my home, but I certainly had them in a few people in my community. And those things are important. We can be that person to those children, and we should be that person to those children. So I'm going to get off that soapbox. That's just really, 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 really important. And just because you're not a mom to a young kid or a dad to a young kid doesn't mean you can't put protective factors in people's place. Even as a treatment advocate or as a recovery coach, I'm still putting protective factors in place for my clients when they call me, right? So we can still do that. We still have a very powerful role in these people's lives. Okay, so when we're talking about substance use disorder and mental health, these risk factors and protective factors are almost exactly the same. They're overlapping. Everybody talks about what comes first, the chicken or the egg, right? Was it the mental health? Was it the substance use? And there really isn't a definitive, I feel like. For some, maybe there are, but for the most part, we don't necessarily know. But do we need to know, right? Because we're at this place, this person has a co-occurring disorder, they struggle with mental illness, they're struggling with substance use disorder, and what can we do? What can we do to help them? So I thought this information was interesting. I wanted to share it with you guys. So 3 possibilities that could explain why substance use disorders and other mental health issues are co-occurring, right? We hear that word co-occurring all the time. What does that even mean? So basically that means there's common risk factors that contribute to those that struggle with both substance use disorders and mental health disorders. Genetics, we talked about ad nauseum. It's the same with mental health disorders, right? So ironically enough, I don't really know a ton of family history, although I still strive to know more because that's just how my geeky brain works and I want to know. Obviously, I know that substance use runs in my family. As far as mental health, I'm not sure. But knowing my family, like my siblings, my mom, my nieces and my nephews, I know it to be true. I just don't necessarily know kind of where it's coming from. But there are definite mental disorders in our family, whether it's depression, anxiety, OCD, all of those things, right? Bipolar. So In addition to genetics, it's the same thing with mental health as it is substance use disorder. There's environmental factors such as stress and trauma. Trauma, which we're going to get into, can be passed down through generations. And this is so important. And I don't think a lot of people really understand the impact of generational trauma. And I don't think for a long time I really understood either. And I'm so grateful that I do now, and my daughter is still young. But here's a quick story. I'm going to keep track of the time. So like I mentioned, I was raised by my grandmother because my mom was in active addictions. My grandmother was a Gold Star mother. So I had two uncles that went into Vietnam. One came home, one didn't. My uncle that died in Vietnam died December 12th, 1970. And my grandmother will explain it to me, or had explained it to me. It was basically around Christmas time. By the time that she was notified, the house was decorated for Christmas and, ready to go. She had two kids at home still, while the oldest was serving in Vietnam. And the soldiers came to the door to notify my grandmother that she had lost her oldest son. It was like that Miss Havisham moment in the, totally drawing a blank on the movie, on the book, but it's that moment. Like every one of us have experienced some type of a traumatic event where we can go back to the moment, the sights, the sounds, the smells. My grandmother very vividly explained that moment to me so viscerally that I felt it. And I continue to feel it. I mourn my uncle that I never met. My grandmother never celebrated Christmas again. So she would, in December, almost always keep her blinds closed. Not one Christmas present, not one Christmas decoration, not one Christmas light. She hated Christmas. She was depressed. She wore black for 10 years after my uncle died in Vietnam. Top and bottom and socks and shoes, nothing but black. And that was my life. That's who raised me. So you can imagine that I was really not a big fan of Christmas, right? I've never been a big fan of Christmas. I always get depressed around Christmas time. Why do I get depressed around Christmas time? Because that's how I was raised. That's the generational trauma that has gone down from my grandmother right to me. And guess what? It stops here because I have an awareness of this generational trauma, and I refuse to allow it to affect my daughter and then her families to come, right? So, but we need to be mindful of that. And how do we acknowledge that? And how do we break free from that? And I have to say, it wasn't until my grandmother finally passed away. She was like 94, God bless her. She was the most amazing woman. I don't want to paint her in a bad light. She was a woman of faith. She prayed every single day. She prayed for my brothers for, their entire life, my uncles, my father. Like, she was an amazing, strong woman. But when it comes to Christmas, like she hated it. She was depressed. It was horrible. Same for me. So what we need to acknowledge is that, well, when she passed, I should say in 2017, I felt a physical release from my shoulders when she passed. And she passed in December, oddly enough. So it was the month that my uncle passed away. It was probably a week after he had passed, obviously several, decades later, but and I thought to myself, I can finally let go. She's gone and she's at peace. And I no longer have to hold on to that depression. I no longer have to hold on to those negative feelings associated with Christmas. I can be relieved of that. And I can now celebrate Christmas and have joy surrounding this Christmas holiday with my daughter so that she's not affected by those things, right? So this trauma, we can pass it down. We can be mindful to not pass it down. But my grandmother didn't understand any of that stuff. She wasn't trying to, make me miserable and make me depressed and make me hate Christmas as much as her. That wasn't her intention in sharing that information, but that's what happened. So we need to be mindful anyway. So the genetics is huge, the environmental factors, but the trauma, we need to be aware that it's not just affecting us, but it's affecting our generations if we allow it. So that's one. The second one is mental health disorders can contribute to substance use and substance use disorders, right? So, there's studies upon studies upon studies found that people with mental health mostly anxiety, depression, PTSD, use, right? No big surprise, drugs and alcohol as a form to self-medicate. So what came first, the chicken or the egg? Well, someone had a mental health disorder. They were struggling with depression. They were struggling with anxiety. Well, if their parents are unaware that they're struggling, their school counselors are unaware that they're struggling, what are they going to do? Their friends like, hey, here, drink this. Hey, here, smoke that. They're going to give it a whirl. And what is it going to do? Well, these drugs temporarily help with some symptoms for mental health disorder. So they take them, and maybe in the beginning stages, they're like, wow, that made me feel so much better. But over time, it makes the symptoms so much worse. So my younger brother really struggles with some of those things, anxiety, depression. And it was really, really severe back when he was younger. And, he's drinking and smoking. And I think for a period of time, he felt good. And then at one point he was like, I just can't even smoke pot anymore. It makes me so paranoid and all of those things. It was temporary in the beginning when he started, it did make him feel better. And it did subside the anxiety and the depression and all of that. But over time, it actually makes the symptoms worse and everything else is exacerbated because of it. So that's important information for our kids to have, again, age appropriate, but it may be good for now, but at some point you're going to hit a turning point and it's actually going to be more harmful to you than good. And or because of the brain changes, and people with mental health, it enhances the rewards that we get from substances. So, maybe someone that doesn't struggle with depression or anxiety smokes, marijuana or uses cocaine, and it's like, yeah, okay, that was great, but I could take it or leave it. But someone that has that disorder, mental health disorder, they're like, like that was amazing. Like we have got to do that again. When is the next time we're going to do that? So those are some of the ways that, I guess we kind of like battled back and forth, the chicken or the egg, what came first, the mental health or the substance use. And then sometimes substance use actually triggers mental health disorders, right? Which that's not new information for anybody. So someone starts using drugs and or alcohol, and then they become depressed. They become paranoid. Alcohol is a depressant, right? So they then develop a depression. They then develop an anxiety, and that was exacerbated by their substance use. So just a couple of examples of kind of how it can happen. It can either be mental health first, exacerbating the substance use exacerbating the mental health. Either way, I don't think there's very many people I've come across that haven't experienced both, right? So most people that are in treatment right now, if we went through Banyan treatment centers or any other treatment center and asked each individual patient, have you ever struggled with depression or anxiety or PTSD or any mental health disorder? I'm going to guess at least 80 to 90% are going to say yes, right? So it's pretty high percentage. So most people have a co-occurring disorder. Okay, I'm going to pause. We're going to switch. We're going to talk about trauma. I'm going to take a drink of water. Does anybody have any questions?
You're rocking it, Tara. Such a great job. So much good information. Thank you.
All right. Trauma. Okay, so we've talked about genetics. We talked about our environment, talked a little bit about mental health. Next up, trauma. One of my favorite things to talk about. Of course, Amy's here, so it makes me a little bit nervous because she's really the trauma expert. I'm not the trauma expert, but keep in mind that this information is coming to you from someone who is not a clinician. I'm not a healthcare professional in any way. I am an individual that struggled with my own substance use disorder and that has experienced her own trauma. So this is coming to you from a very different lens than a clinical lens. Okay. So there's a link between trauma and substance use disorder that we cannot ignore. I don't know how many people, sorry, I advanced too fast and I'm missing a graphic on this, but I don't know how many people here have read the book, The Body Keeps the Score. But if you are interested in trauma in any way, shape, or form, I highly, highly recommend that you get this book and read this book. This book was a huge, huge game changer for me. I obviously have a lot of self-awareness. I've been in recovery a long time. I've done a lot of different types of recovery. I've done, like regular AA, NA meetings. I've done a little Celebrate Recovery. I've done church, right, has been a big part for years now of my recovery. I never understood trauma and the way in which it affected every part of my being until I read this book. So it brought me a whole new awareness. So for example, I'm reading this book. This was a couple of years back now. And in the very beginning, it talks about how trauma affects or presents itself in our youth. So my daughter, 11, 12 years old, right? She doesn't have the same vocabulary and the same life skills as I do. So if she's feeling some kind of way, she cannot communicate it to you effectively in a way that I can communicate it to you, right? So kids communicate trauma usually through aches and pains in their body, right? Whether it's belly pain or headaches or what have you. So I'm reading this, and as I'm reading this, like I have this huge aha moment to the point that I have to close the book, had to get up. I had to walk across my hall because my mom was living in my in-law apartment. She's no longer here living with me anymore, but for 10 years, she was living with me in my in-law apartment. I run over to my mom's and I was like, this book just validated me. I am not hypochondriac, because my entire childhood, I had eye problems, headaches, stomach aches. It existed, you name it, I had it. I was in the nurse's office so frequently in grade school that the nurse would take me home for weekends because she knew what was going on in my house and she wanted to give me a break from the chaos and the trauma and the dysfunction. I had headaches and stomach aches and vision problems and just everything. Why? Because I couldn't say, I'm feeling neglected. I'm being, abused, mentally, emotionally, verbally. I can't say the cops just raided our house last weekend because my father said what happens in our house stays in our house and I'm to tell nobody. Right. So that was private information. I can't share it anyways, even if I wanted to. And I didn't know how all of that was affecting me, mind, body, and soul. But my body knew, and my body was screaming out for help, right? Constant headaches, constant stomach aches. So I say that because anybody that deals with kids needs to understand, if you have a kid, I feel like everybody has at least that one kid that's always complaining that their head hurts or their belly hurts, or pay attention to those things. Those are red flags, because our body just will scream out for help. If we verbally can't scream out for help, our body's telling us we need help, something's happening and we need relief from whatever it may be. So that's an amazing book. I highly, highly, highly recommend it. A lot of what I teach on comes from that. And the other thing that is, I don't know where it went, that's not on this slide, is the ACEs study. ACES, adverse childhood experiences, is another really big thing. If you are not familiar with that, I recommend you get yourself familiar with that. You can Google ACE study and you can find out some information. It was a 2-year-long study. There were 17,000 study participants in the ACE study, and basically a 10-question questionnaire that these 17,000 people participated in. So 17,000 people answered these, 10 questions, and you can Google this. You can Google the test. You can get the test. You can take the test. I've taken the test. Had my sister take the test because I was curious, both of us growing up in the same household, what the score would be. Your top score would be a 10. If you say yes, that you get a 1. If you say no, it's a 0. My sister scored a 9. I scored a 6. I did it with my daughter a few years back. She actually scored a 3, which is not great. But she remembers the split with her dad and myself. So that was pretty traumatic for her, dad being here, dad not being here, unfortunately. So she's, not only is she genetically predisposed to addiction, now she's experienced a little bit of childhood trauma because mom and dad aren't together, and she's trying to navigate how that works, and all of that, which is really sad and hard for a kid. So anyways, this ACE study, so you can take it. And after those 17,000 people answered those 10 questions, it basically said the higher, the long and the short of it, the higher your ACE score, the more likely you are to develop substance use disorders, to develop mental health issues, but also heart failure and, obesity and chronic COPD, all of these other things, right? Because of the stress and the trauma and what it does to our body. It affects our health in so many ways, and we don't know that. So it's wild to me that when I found out about the ACE study, which had been done in like 97, I want to say like 95 to 97, if I'm not mistaken. So we've been sitting on that information for over 20 years, and it's not in our public school system, and it's not in our pediatrician's office. It's beyond my control. I don't understand why we're not using it as a preventative tool to identify kids that may potentially be high risk and put some protective factors in place for them. To me, it sounds very simple thing to do. I actually had approached a pediatrician that I know that works with the local opioid task force, and I'm thinking, this person will be perfect. She gets it. She's a pediatrician. She volunteers, on this task force. And I said, what do you think about doing a small study in your practice? And like, we have these kids and their families fill out the ACE test, and we put some protective factors in place. Obviously it's not going to be a quick thing, right? It could be like a 2-year study, whatever the case may be. It could be longer, it could be shorter, whatever. And she basically said to me, and I was so sad and so shocked, but she was like, well, first of all, we don't have the manpower to sit and do a 10 questionnaire with these patients, right, and their families. And well, what do we do then if the kid is high risk? We don't have any resources. We don't have a social worker. We don't have any of that stuff in the practice. Like, we can't do this. So here I am screaming from the mountaintop, right? Like, we know the body keeps the score. We know how trauma affects us. We know that our overdose rates are through the roof. How many people did we lose last year? Over 100,000 deaths to just opioids, not alcohol, just opioids. Let that sit with you for a second, okay? Over 100,000 deaths because of opioids, not including alcohol. How many children lost a parent or a caregiver? That's a traumatic event. They're genetically predisposed because their parent struggled with a substance use disorder. What are we doing to help them? What are we doing to prevent them from walking in the same footsteps? Nothing. If we are, let me know. I mean, I know Amy's done an awful lot of work, but I feel, and it's just me, Tara, whatever, but I feel like it should be in every school system. Every school system should be doing this, sending information home to parents, giving out resources for local therapists. Maybe there's a support group in each school district for a kid who lost a parent that struggles with opioid disorders, right? Or alcohol disorders, or whatever. Kids in the foster system. How many kids do we have in foster systems? Why don't we have support groups for kids in the foster system? I was a foster kid. There was nothing like that when I was growing up as a foster kid. And God forbid anybody know I was a foster kid. I never wanted anybody to know that. That's so embarrassing, right? Nothing, no prevention, no protective factors, no nothing. We need to do better as a society. We need to do better. There is so much room for growth here. And I don't want to, there's a lot going on, and there are good things. Like DA Early's got some really great stuff in some school systems. Some school systems have stuff, some don't. So I'm not like knocking all of them. I'm just saying, like, this should be something that should be across the board in every school system and every pediatrician's office. We should be having these conversations. ACEs should be just a normal name. Everybody should know what they are. We should be aware. Therapy should be like a mainstream thing. I think everybody should have a therapist.
Tara, you're practically channeling Nadine Burke-Harris. She has a TED Talk, and I think you even posted on Facebook where she's shout this from the rooftops. Why are we paying attention to this, right? And then she does one 10 years later that's like, we know it, we don't want to face it. It's not about we know it. We just would rather be sick than face our trauma. And boy, is that devastating. But I think there's just agree. Wow. We know this is really impactful, but we're not addressing it. And it's the adults. We don't want to look at our stuff. We don't want to face our trauma. We're not doing the work ourselves because we just aren't up to the task. And therefore, we're really not helping younger people. So you're not alone with like, hey, let's pay attention to this. We keep trying. Yeah. That's why we're doing this.
Yes.
Keep working away at it. You can do it.
I love Nadine. Yeah. And I have posted her stuff. She's amazing. I would, and that was kind of like, secretly that was my hope with this like pediatrician that I was talking to. I'm like, maybe she'll be like the Northeast region, like Nadine, like she can be the trendsetter. And it was a no. And it was like, so disappointing. But it didn't stop me and it won't stop me. I will continue to shout from the rooftops. I will continue to share my story. I will continue to encourage others. I will continue to educate, and I won't stop because I feel that that's my mission and that's what I was called to do. So I'm going to continue to do it. So what is trauma? Trauma is an emotional response, and it's caused by experience either a single incident or a series of distressing, traumatic, emotional, or psychological events, or both. Just because a person has an event doesn't mean they're going to experience trauma, right? We're all different. We all have different personalities. We all have different, I'm trying to think of that. We all have a different like capacity, right? So like some people say, don't make a mountain out of a molehill. Well, it may be a molehill to me, but it's a mountain to you. So everybody responds differently to trauma. So not everybody is going to respond in the same way, but, there's definitely been people that I've met along the way that are like traumatized by something that I thought was like, huh, really? But I mean, my trauma is pretty significant, right? Like it was not uncommon to, have our, have police banging on the door and, we've been raided and we were robbed and, just the stuff that I experienced as a kid, which I think it's funny now because obviously I'm an adult and, I'm in a different place in my life, but I just thought that stuff was normal. I didn't know any better. And I also didn't know like how it's affecting my body. So just because someone experiences a traumatic event doesn't mean they're going to experience all of these additional things, right? It's not a one size fits all. When someone experiences trauma, there could be shock and denial. Those are usually the like immediate reactions. And then there's obviously long-term reactions that included but not limited to mood swings, relationship challenges, flashbacks, and physical symptoms. So one of the traumatic experiences as a kid was my uncle that did come home from Vietnam. He was a Marine. He did 2 tours at 19 years old and came home with a pretty bad drug problem. Wonderful human being, would give you the shirt off his back. He was my Uncle Hutch and he would do anything for me. But he struggled with, his experiences in Vietnam. And I remember multiple times him having flashbacks and running out of the house and running into the woods. One time he brought my older brother with him when we were really young. He was probably not even a teenager yet, and held him at knife point in the woods because he was having a flashback. He wasn't himself. So I unfortunately learned really early on what flashbacks were and what trauma was and what PTSD was. Even though I was experiencing it myself, I was also watching it kind of, unfold before my eyes. And then physical symptoms. So it's funny because I work with first responders. I am not a first responder, but I can really relate to a lot of first responders. 9 times out of 10, if they're in law enforcement or they're a correctional officer, when they go somewhere, their back is never to the door, right? They're always facing the door, no matter where they sit in a restaurant or wherever they are, they're facing the door. Same with me. I do not like to go to concerts or big events. It's very anxiety producing for me. I don't have any control over the situation at any moment. Anything can pop off. A fight can break out. Like, who knows? I don't know. But here I am as an adult, as a professional, but I still have these fears because of we would just be at a cookout at my house, no big deal. And 10 minutes later, someone's on the ground bleeding. There's an ambulance, a cop is there. Who knows? Like, you just never knew what was going to happen at any given time. So I don't like to go to events like that. I don't like fireworks. I don't like the sounds of it sounds to me. So both my uncle and my grandfather, both my grandfathers actually had the gun salutes at their funerals. And so I don't like the sound of fireworks, because it just brings me back to that time. And I literally will sit there. My daughter likes to go, so I force myself to do it. And I'll just sit there with like tears streaming down my face, because it's a very uncomfortable thing for me. It's a traumatic response. And it just is what it is. I can avoid going to those things if I can, right? But I'm not going to like take that away from my daughter to experience that. If I can get somebody to take her, that's always best case scenario, but sometimes I get stuck doing it. But those are things that, it's now in our genetics. It has changed the fiber of our beings. And that's just something that's going to happen. It's just an event. It's a symptom of that event. These are types of other traumatic events. We are all very familiar. Domestic violence is huge, sexual abuse, sex trafficking, verbal abuse, accidents. I have a cousin who was in a car accident with her mom, my aunt, when she was a teenager, and she is, I don't know, mid-30s now, and she still does not have a driver's license. She owns a business. She's a hairdresser. She's successful. She refuses to drive. She won't do it, based on that. Refugee trauma, that's huge. I don't even want to get into what's happening to those poor people trying to leave their countries and coming over here. Violence within our community. I live in Fitchburg, and we had a stabbing downtown a couple weeks back, and I actually had a friend witness that. It was right at a stoplight. She was just minding her own business in her minivan. Thank God she didn't have her kids with her. And the person, next to her gets out of his car and proceeds to stab someone right on the sidewalk, right in front of her. And those things, we experience those things. We sometimes, we can't control what happens around us, right? And so it's really important for her to be able to process that and not sit with that, because we cannot always control the things that happen to us, but we can try to be mindful and heal from the things that we do experience. This is really, really interesting. And I am learning more and more and researching more and more about how trauma physically affects us. So we know that trauma produces physical changes in our body. One of the things that it does is recalibrates the brain's alarm system. It increases stress hormone activity, and it alters, there's alterations in the system that filters relevant information from irrelevant information. This is really interesting. So like when I don't like noise in general. My house is super quiet. Thank God my daughter is quiet for the most part. Obviously, if there's like a family function or birthday parties, it's different. But for the most part, 9 times out of 10, it is very quiet around me, everywhere I go, what I do. I am I'm jumpy. I scare easy. I don't like loud noises. So if I'm driving, I'm in my own little world because I'm thinking of 5,000 things happening all at the same time. I'm driving, someone beeps, I jump. I hate it. Hate it when people beep. I'm like, stop beeping, people. Like, it's so disruptive. So there's things that happen in our body when we hear something, see something, smell something. It's just a reaction because our brain's recalibrated. So I put cortisol there because I recently, and we'll talk about this and I'll continue with this. So I recently was diagnosed with an autoimmune disease, which we'll talk about on the next slide. I went to get some blood work done. And when I sat with my provider to go through my blood work, she said to me, your cortisol levels were really high. Did something happen the morning you went to go get your blood work done? And I giggled and I said, no, absolutely not. I'm like, that's my baseline, because I'm always in fight or flight mode because of the trauma. So if you think about it, and this is, these are all kind of relatively new realizations for me, right? So my childhood was full of traumatic events. Then I get sober at 19 years old, but then for the next 20 years, my life is full of traumatic events because of my brother's active addiction, right? When I say traumatic, I mean traumatic. Like my brother was, ran from Massachusetts to California, ended up getting extradited back to Massachusetts, and then California. He was like shot at multiple times, held up by gunpoint, car accidents. I almost lost my younger brother. When the phone rang, we never knew what was going to be on the other end of that. So now 6 to 8 years ago, they get sober, right? Well, that doesn't just all go away, right? I'm still hyper vigilant, even though I practice meditation, I pray, I keep my environment serene, I light candles, I work really hard at trying to be peaceful and mindful, but those things, that alarm system, I cannot get it to settle. Even 26 years sober now, and 8 years post my brother's recovery, my cortisol levels are still high. So I'll touch back base in another couple of months after I have had these supplements for a period of time and let you know if that cortisol level comes down. But I mean, that's reality of trauma. As those cortisol levels are going to stay high, regardless of what's happening. We are always going to be hyper vigilant, regardless of what, depending on what our trauma is, right? We're going to, not like loud noises, or we're going to not trust men, or we're going to, you name it, right? But depending on whatever traumatic event we had and how it affected us. So our trauma changes us. We always are hyper vigilant to threats. I'm very untrusting. My boss used to say, trust but verify. I'm like, okay. I'm like, but I trust and verify, and I still don't trust. So Vander Kolk in his book said that trauma is one of the West's most urgent public health issues. So let's go back to our kids that have had traumatic experiences of losing their parents and no protective factors, maybe growing up in a foster home, and what's going to happen to them. So here's some of the, let me go here first, and then I'm going to go back, because I want to share this information with you, because this is really important. So we talked about ACEs, and we talked about ACEs, a high ACE score causing chronic health issues, right? Well, because our alarm system is calibrated the way that it is, because we're unable to take a deep breath and relax and not be hyper vigilant, because we're always in fight or flight mode, there's physiological reactions to being in that fight or flight mode. And those include fibromyalgia, chronic fatigue, and other autoimmune diseases. So there are 6 to 12 million people that have been diagnosed with fibromyalgia. And I know a lot of people are like, oh, fibromyalgia is not a thing. It's not real. People are just, making it up. It's a real thing. People are in pain, but it's not all. A lot of it is directly related to trauma and being in that fight or flight mode without having the ability to shut it off. Chronic fatigue, 1 million people. Autoimmune, 23.5 million people are diagnosed with autoimmune. And it took me, I've been having these issues that I finally get diagnosed for over 12 years. It took me 12 years in going to see a functional medicine provider, because my PCP and my endocrinologist couldn't diagnose me. I don't know why. They just didn't do the right blood work, whatever. I sought the help of a functional medicine provider and finally got a diagnosis of an autoimmune disease. So now I'm working with that person. Things are fine. It's not like end of the world or anything like that. I'm grateful to have a name for my symptoms, and I'm grateful to have a plan to work through that in a healthy way. But so we have all of these people out in the world struggling with COPD, chronic heart failure, substance use disorder, mental health issues, fibromyalgia, chronic fatigue, autoimmune. And it's all really, if we look back at it, rooted in some kind of traumatic event. We have the information, the body keeps a score. We have the information about ACEs, yet we still do nothing. We still do nothing. And I'm not gonna say it's because the government and the medical institutions make so much money off of us being sick, but I can't help but think in some way, shape, or form that may have something to do with it. But I'm just going to throw that out there and leave that there. How can we've all probably experienced our own trauma, right? But how can we be trauma informed? How can we help those that we're working with? How can we not re-traumatize them? So I recently had a conversation with a colleague who is on MAT, successful in his recovery, and he moved from Massachusetts to another state. And he told me that he's been trying to find a provider for Suboxone in this other state, and that his new PCP in this other state said he's not comfortable writing a prescription for Suboxone. And so that led him to looking for another provider for the Suboxone. He went for his first appointment with this new provider, and whoever the person was that went in to ask the intake questions proceeded to say, ask questions about his, substance use, how long he's been sober, et cetera. But then said, were you ever sexually abused as a child? Did you ever offer yourself, for sex purposes when you were in active addiction? Like all of these really personal, triggering types of questions. And, luckily this person's over 4 years recovery. He was kind of like, okay, this is weird, but whatever, I'm going to answer the questions because I need my prescription. After he goes through that intake and is, asked all of these potentially triggering personal questions, he's just released from the doctor's office. There wasn't any follow-up. There wasn't a conversation with a therapist. There wasn't any debriefing. There wasn't any I asked you some pretty triggering things like, are you feeling okay? Are you feeling safe? Is there anything that we can do to help support you right now? No, none of that. So I imagine someone that's newer in recovery that may not be solid, right? That may not have support system, that maybe 30 days sober, 60 days sober, 90 days sober, and going in to get a prescription and being triggered by asking, like, did you ever, do any sexual favors for, drugs when you were in active addiction? Were you sexually assaulted as a kid? Who wants to talk about that or think about that, especially in that frame of mind, that early and, not stable in your recovery? I can't, it boggles my mind. But you're here, so that means you want this information. So some of these things are really important. I would screenshot this and save this, but space is a really big one, right? Allow time and space for the individual to calm down, to get a right perspective. People that have survived traumas have difficulty regulating their emotions and take a longer time to calm down. Now I'm 26 years into my recovery and I'm older. So I still do have these, moments, far and few between, but I have them. And when I do get upset, even if it's not upset, it takes me a long time to process and to calm down and to be able to talk. So if you say something that upsets me, I'm going to kind of internalize, and then I've got to go through like my systems, right? I got to go through my recovery stuff. I got to go through my step work, and I got to say, like, is there fear? Is there, is it affecting my self-esteem? Like, what is it about the situation that's upset or triggered me? You got to process that, like pray through that. Right. And then I'm at a place where I'm like, okay, I understand what happened. I don't say it was silly for me to get upset because that was just my natural response. I didn't respond to the individual. So there's no apology necessary. I've learned not to speak out of anger, right? Or speak in that moment when I'm upset. I ask for space to process, but it takes me a long time to process. 26 years sober, right? Doing this work for a really long time because it takes time. It's just going to take time. And I'm not going to ask for forgiveness for that. I mean, it's everybody's going to need their own time and space, and everybody's looks different. But just be mindful of that, right? Don't be pushy. Allow people the space to be who they are, to feel what they feel, to process what they need. Predictability, right? Nobody wants to be surprised. We don't like, I hate surprises. Don't throw me a surprise party. I like to know everything about everything. If I'm going somewhere, I want to know where I'm parking. I want to know what time I need to be there. I want to know what time it's going to end. I want to know what to expect while I'm there. So be predictable. So those of you that work as recovery coaches or treatment advocates, all of those things, like we feel safe when you do what you say you're going to do. So always do what you say you're going to do. And if you're running late, or if you can't come through on a promise, or, something like that, communicate that. Hey, listen, I just ran into traffic. I wanted to communicate that to you. I'm really sorry. I'm running late. Or, what, I asked my boss, I'm unable to do that. I'm so sorry. I probably shouldn't have promised you something I wasn't positive I was going to be able to deliver on. Please forgive me. Like, that won't happen again, right? Transparency. But those that experience trauma really enjoy being interacting with someone that provides that predictability and that stability, because we haven't had that, right? Be supportive. It doesn't take any education or experience, right? To just be kind, be loving, be patient, be empathetic. And if you act that way, then you would expect someone to do that in return, right? So we can't expect someone to treat us a certain way if we're not going to treat them that same way. So these are just some good examples of how to work with someone and being patient that's experienced trauma. This I wanted to share because I found really, really interesting as well. So there was an article in the New York Times, February 2022. There was a study done in the year after people getting COVID. People that were tested positive for COVID were significantly more likely to be diagnosed with a psychiatric disorder than people that hadn't gotten COVID. 39% more likely to be diagnosed with depression, 35% more likely to be diagnosed with anxiety. COVID patients were 38% more likely to be diagnosed with stress and adjustment disorders, and 41% more likely to be diagnosed with sleep disorders than those that did not test positive for COVID. I know very few people, probably on one hand, that didn't test positive for COVID at one point or another. So this is a huge, huge population of people. So these are people that have never had any issues before. They're not exasperated. They're new symptoms, new onset of symptoms just because they tested positive for COVID. Additionally, there were 34% more likely to develop an opioid use disorder, possibly from the drugs prescribed for pain, 20% more likely to develop a non-opioid substance use disorder, including alcoholism. So I don't know if, any of you kind of paid attention in the beginning stages, but I thought it was crazy that they kept liquor stores open when they closed everything down. It was listed as essential. And I think part of the reason that the liquor store was considered essential is because you can actually die from an alcohol withdrawal, right? You can't die from an opioid withdrawal, although you feel like you're going to die because you get really, really sick, but you can physically die from complications of detoxing from alcohol. So I'm guessing that's why they didn't close liquor stores. But what that did was encourage people to use liquor during COVID to self-medicate. Our anxiety's through the roof. We're bored. We can't go anywhere. So we definitely, as a treatment provider, saw a huge uptick in alcohol use and people coming in for treatment for alcohol misuse during like the months and even year or so following COVID. So I thought that was really interesting. I wanted to share that with you guys. When I talk to someone that's struggling with any type of mental health, one of the first things I ask them is, did you ever test positive for COVID? Just because my nerdy brain finds it fascinating. I mean, I don't fully understand it. And at some point we probably will, and we won't be happy about it. But it's quite interesting that, people that did not have any depression, anxiety, or any of those types of mental health issues had tested positive for COVID. And now all of a sudden they're having those issues. That's 39% of them anyways. So I find that interesting. I like to share that. Okay. When we talk about treatment, we're gonna kind of switch gears here. It's not a one size fits all. It takes a village. Again, our words are important, right? So if you know somebody that's struggling with addiction or in their early recovery, your words matter. You got to be encouraging, right? You can't be like, oh, you relapsed again. Like those those words hurt. And they like viscerally hurt. And we need to like not speak to people that way. Social determinants of health are a big part of it, right? So someone comes into a treatment center like Banyan, they're doing well, their 30 days is up, they leave treatment. Well, do they have a place to live? Is it a supportive environment? Is it a sober environment? Do they have access to healthcare? Do they have access to medications they might need? Do they have health insurance? Do they have a job, economic stability? All of those things play a role. So someone can come into treatment and receive the best possible care available. But if those social determinants are not in place when they get home, how successful are we expecting them to be? So we need to be holistic. We need to think about things on a holistic plane, right? It's medical, it's substance, it's mental, all the holistic stuff in between, whether it's yoga, meditation, church, whatever it is that works for you. We need to address mind, body, spirit. The entire thing has to be addressed in order for us to really fully recover. I love this because it just, for me, it's me. I told my therapist, my therapist is an EMDR trained therapist, and I've done a lot of EMDR with her. And I was like, this really frustrates me sometimes that, this triggers me, or I'm upset by this, here I am 20 something years sober. I've done my step work actually twice, because I did it year 3. And then I did it again a couple of years ago just to refresh and clean up. And like, I'm constantly working on myself and trying to be the best version of myself that I can be. How is it that these things are still triggering me or upsetting me or bothering me, whatever the case may be? And she kind of like talks about it in like the peeling back of the onion, right? Like there's only so far that I'm able to go when I'm like diving into the trauma that I can talk about, that I can be vulnerable with, that I may not be ready, right? In the very beginning, early stages of recovery, we might just be like pulling off the outskirts of the onion, and we're just sober and we're surviving, and that's okay. And then, year 2, year 3, year 4, well, maybe we'll peel back another layer. Maybe we're ready to talk about step work. Maybe we're ready to do an inventory, peel back a couple more layers of the onions. Now we're really like sick and tired of being sick and tired. There's been times in my recovery where I'm like, I can't even stand myself right now, right? Like this life it's ebbs and flows, right? Sometimes I'm in a really great place, and sometimes like I can't even handle myself. Because we're peeling back the onion, and we're doing it in layers, and we're doing it in our own time. Everybody's process is different, and we need to be respectful of that. So it's peeling back the onion. And what do we do when we peel onions? We cry, right? And crying is okay for men and for women. I grew up with my father always beating my brother and telling him that if he cried, he'd give him something to cry about. So even though he wasn't doing it to me, I heard those words over and over and over again as a kid. And so I'm not a crier. If I call a friend and I'm crying, it is a big deal. It took me a really lot to get to that place. I'm completely overwhelmed, and like, what hit the fan if I'm crying, because I don't cry easy. But I've found over the last few years that it is a beautiful thing, and it can be very cleansing. I had to let go of that belief and the words of my father in order to really be able to be okay, just allowing myself to feel whatever feelings I was feeling at the moment. All right, we have 10 minutes left. I'm going to get through this. So this is important information. What is the continuum of care look like? In Massachusetts, we have a policy. It's supposed to be no wrong door policy. So anybody that's struggling with substance use disorder can get treatment in any capacity, any way, shape, or form. They can start at recovery coaching. They can end up, somewhere else in this treatment pendulum. But 9 times out of 10, what happens is someone starts with detox. They're using substances, they need to be detoxed of those substances. So usually detox, which we call ATS, is the step 1, right? So that's a 5 to 7 day process. And it is just that, it's just detox. We are medically detoxing one's body of the substances that they've been using. We're usually doing that with medications, because if we don't, they'll get really, really sick and be really miserable and probably leave and go get high. So detox, again, is just that. It's a medical process where you're detoxifying your body of the substances that you've been using. That's a 5 to 7 day program. Then and mind you, they're just detoxing, right? There's not a lot of treatment. There's not a lot of talking to my therapist. There's not a lot of going to groups because people are not feeling well. They're not going to groups. They're just detoxing. They move to step 2, CSS. That's a 7 to 14 day stay. That's where the meat and the potatoes comes in. They're meeting with the case manager. They're meeting with their therapist. They're talking about discharge plans, where they want to go, what they want to do, what their next steps are. They're learning about relapse prevention, and they're learning about different pathways to recovery, and they're putting tools in their toolbox. This is a really important part of someone's program, right? So between detox and CSS, you're looking at a possible like 21 to 28 day stay, always insurance depending. Insurance dictates treatment, which drives me absolutely up a wall, but that's how it is. Now, let me pause and say this. In the state of Massachusetts, and this is pre-closure, right? Those of you that are in the Worcester area are familiar with CHL closing their detox and CSS. Mira Vista and Western Mass closed their detox and CSS. And then someone out in Tewksbury area, maybe I want to say, closed their detox and CSS. Before those closing took place in the state of Massachusetts, we had 400 detox beds and 900 detox beds and 400 CSS beds. 900, 400. So I can get 900 people into a detox bed. They're there for 1 week, give or take. And then CSS, we only have 400. Less than 50% of the people that get a detox bed have a CSS bed to transition into. So again, detox, they've had no treatment, no therapy, no meeting with their case manager, no tools in their toolbox. And they're sent on their way because we only have 400 CSS beds. And so only less than 50% of the people that go into detox can get into a CSS bed. Now, if you're in CSS for 7 to 14 days and only in detox for 1 week, wouldn't it make sense that we have double the CSS beds than we do detox beds, so that everybody gets a chance to complete full treatment? So if that was the case, we would have 900 detox beds and 1,800 CSS beds, but that's not what we have. And part of the reason is because reimbursement rates for CSS are much lower than they are for detox. It is much more financially beneficial to have a detox bed versus a CSS bed, right? So that's one barrier for people getting treatment. 900 detox, 400 CSS. So if they can't get into CSS, what do? PHP-IOP is an option. Some PHP-IOPs have housing attached to them, some don't. So that's always a barrier. But PHP is outpatient level of care. It's basically all that programming, getting those tools in your toolbox, learning about relapse prevention, learning about different pathways of recovery, learning tools that we can use in our daily lives to maintain our recovery. So that's an important step. Obviously, we've got halfway houses, co-occurring enhanced programs, which are phenomenal. I'm a huge fan of co-occurring enhanced programs. They're longer term residential stays for patients that have both a mental health disorder and a substance use disorder. I think all of our programs should be co-occurring enhanced. And I hope that we continue to work more towards that. We've had lots more co-occurring enhanced programs come online, and I would love to see much more. We need much more. So that's a really great aftercare option. Sober housing, obviously. Medication for treatment is available at any time. So if someone doesn't want to go inpatient and they just want to get on Suboxone or methadone, that's available to them. They can do that. We have obviously AA, NA, Celebrate Recovery. There's Refuge Recovery. There's so many pathways. I could spend 2 hours talking with different pathways. And then recovery coaching. I tell every single person that leaves treatment, you got to connect with your local peer recovery center. There's recovery coaches housed in every peer recovery center, and lots of other organizations across the state now. But it's so important, and it's such a great tool in someone's recovery to connect with a recovery coach and have that level of support right off the bat, fresh out of treatment. It's really a beautiful thing. So I really encourage people to get connected and get a recovery coach. Okay. So something to think about when we think about treatment, and I love to always bring this analogy up. You think about someone that's broken their leg. You don't just put a cast on it, take it off and say, okay, you're good. There's relearning, there's physical therapy that happens, and you want to get yourself back up to the place that, you were before you broke your leg, right? So the same goes for addiction treatment, right? We move this, I can't talk. We remove the substance, but then we need to learn how to deal with life on life's terms, right? We need to know how to handle an emotional event without self-medicating. That's a big deal. That's not an easy thing to do, right? I only used substances for about 7 years. Imagine someone that used them for 17 years. And now we've removed the substance. They want to stay sober, but they're going through a divorce. They lost their job. Their kids mad at them. They have to deal with life on life's terms now, substance free. That's not an easy thing to do. They have no coping mechanisms, right? No one put any protective factors in place when they were kids. So these expectations are high. We need to understand that once the substances are removed, that's really when the work begins. And we can't do that alone. We need support. We need our community. We need these peer recovery centers. We need PHPs, IOPs. We need other recovering people in our lives to help us one step at a time, one day at a time, learning how to live life on life's terms again. I often see people going into detox and they come home and the family's like frustrated if there's a relapse or a reoccurrence. They think they're just going to go away to a 28-day program, a 30-day program. They're going to come home and they're going to be all better. Well, here I am 26 years later telling you that the work never stops. Recovery is a lifelong journey, especially if it's co-occurring, right? Especially if we've got the mental health and we've got the substance use disorder. Even if we just have the substance use disorder, we have to relearn everything. And we're slowly peeling back the layers and we're slowly becoming better versions of ourselves. And that sometimes slowly, sometimes quickly. Everybody changes at a different pace. No one recovers the same. So we really need to understand the work that goes in, everything, all the layers of the onion that needs to get peeled back, all the trauma, all the hurt, all the chaos that needs to be healed. We need to relearn how to have a healthy relationship. What is a healthy relationship? Who knows, right? Like we need to learn those things because we haven't had them modeled for us. We haven't practiced them. There's so much, like we literally need to learn how to live life all over again when we get sober. So it's a process and we need to understand that. And we need to be caring and kind and supportive and compassionate as people move through those stages of peeling away the layers of their onion. So look at that right at 2:00. I'm so good. Okay. Addiction to mental health can affect anyone. It doesn't discriminate. Addiction can be preventable. Remember, if you drink or use substances before age 21, you have a 40% risk of becoming addicted. If you wait until you are 21, your chances will go down to 7%. Remember that if you remember nothing else. Mental health, trauma, PTSD, addiction, they're all contributing factors. We cannot ignore them. Think about what someone's been through before you judge them too harshly, please. Because we all have done things and said things that we wish we hadn't. And so I don't know why we think it's okay to judge. It shouldn't be a thing. Treatment's available, although it's very challenging to access for some. It requires constant advocacy and persistence, and it is a lifelong journey. So we can be part of the problem or we can be part of the solution, right? Because our words are powerful. Which are you going to choose? And I am done. Right on time.
Tara, that was so incredible. So much. Everybody, there's no doubt in my mind that everybody learned something. You had so much to offer. That was so comprehensive. Wow. And just, I already loved you and thought you were awesome, but hearing all about all the trauma, all the things that you've overcome, how much you've done your own education and your own work, like whole other level inspiring, my friend. It was really amazing. I hope that lots of people will access this recording and use it and share it out, because what you had to offer was so valuable, and this information isn't out.
Did she freeze?
Yeah, that's been a little iffy. Thank you, Tara. And quickly to steal the spotlight back, we're asking
There,
in
it's
the chat. I've dropped the link for folks to complete a quick feedback form, and that helps us secure funding to continue to offer these free trainings. So thanks so much for taking a minute there before you hop off today. Amy, go ahead, you're back.
Oh, Zoom. Zoom is not my friend lately. Did anybody else want to say anything other than, oh my God, you're amazing, Tara? Because if you want to, jump on in. I'm confident that people got so much out of this. It was just beautiful, and we're so grateful to you.
Thank you.
I'd
like to
It's an
say
honor.
Go ahead,
thank you
Norris.
so much. This was a wonderful training. You covered so much in a short amount of time. And I'm just really inspired and impressed with your determination, your resilience, how you educated yourself. Your whole journey was really inspiring. And I wish you all the best luck in the future. Thank you, Tara, so much.
Thank you. Thanks for having me. Oh, Amy, you're muted.
If you don't already know, you can catch all the recordings at our website, which is worcesteracts.org. And we'll post this as soon as it comes back from Zoom, not my friend, but they'll send it back. We'll post it, and please share it. Encourage people in your life to watch it. Clearly, there is so much learning here. Thank you,
Thank you.
Tara.
Bye. Thank you.